Hello, general psychology students. Welcome to week 7. This week we'll be covering chapter 16 on the treatments and therapies for psychological disorders. Next week, you'll take your Unit 2 exam. The Unit 2 exam will cover chapter 11, personality, chapter 15, the psychological disorders or psychopathology, and this chapter, chapter 16, on the treatments and therapies. So I know last week I had you watch a lot of videos. I think there were 10 of them. I know that was a lot. This week there'll be far fewer talking about the treatments, in part because last week's was so long, but also in part because this week, in addition to learning the information in this chapter, you'll be writing your first writing assignment. And I'm excited to read those. And next week, you'll be preparing for and taking the exam. So there's fewer videos to watch this time over this chapter. Well, let me start to share the screen with the PowerPoint slides. And we'll get right into it. So I know you already know how to get access to these PowerPoint slides at this point in the semester. So we're talking about chapter 16, therapy and treatment. And last week, we talked about so many of the different psychological disorders, all the anxiety disorders, and then some of the mood disorders, and some of the dissociative disorders, and schizophrenia, and the personality disorders, and the childhood disorders. And we just went through, I want to make sure that you know the symptoms or characteristics of each of those disorders. And in this chapter, we're going to talk about the different therapies that exist for these different disorders. But if we don't get therapy, if we don't get help, if we don't do anything, we know that people are going to suffer needlessly. And some of the people are going to end up homeless or in our correctional institutions, in our prisons, in our criminal justice system. In fact, this one study in 2011, I know it's 10 years old, but found that about a quarter of the people who are in homeless shelters suffered from a severe mental illness. So either schizophrenia or bipolar, but not in a high functioning version of it, but in a more severe form of it. And correctional institutions also report higher number of individuals with mental health issues than people who are not in prison. So we don't want to, as a society, say, well, if people have a mental health issue, they'll just end up in a homeless shelter, end up in the prison system. It's not a good use of our resources. Instead, it makes a lot more sense for us to get these people the help and treatment that they need, so then they'll be a contributing member of society. So what are the treatments that we have? We have a whole bunch of them, but we're going to put them into two categories. Psychotherapy, which is psychological treatment of the disorders, non-medical process to help individuals with psychological disorders to recognize and overcome their problems. This is oftentimes called talk therapy. And we're going to spend a whole bunch of today's lecture talking about all these different talk therapies that exist. We also have biomedical therapy. Now, most of the biomedical therapy is drugs, but there's also ECT, electrical convulsive therapy. There's also a new therapy that's come out, transcranial magnetic stimulation. It's a very new technology involving running highly directed pulses of electrical energy into the brain. And this has some promise in treating depression. Now, there isn't anyone in Lawton that I know that is doing this at this time, but that would be another form of biomedical therapy. I think we'll be seeing more and more of that as time goes on. And so this is a picture of some group therapy going on with people with PTSD. So let's talk about the different psychotherapies, the talk therapies that exist. We've got the psychodynamic therapy, play therapy, behavior therapy, cognitive therapies, cognitive behavioral therapy, and humanistic therapies. So I told you there were a lot. There's 6 of them. I'm going to go through each one of them in turn. Okay, so psychodynamic theory comes from Freud's theory. So think back 2 weeks ago to when you were studying Freud. Remember how Freud, his psychodynamic theory, says that we've got these unconscious desires. Your super ego and your id are unconscious, and some of the super ego is conscious, but most of it's unconscious, and they're at odds with one another. Remember, the id wants what it wants now, operating under the pleasure principle, and the super ego is doing what doing what's moral and appropriate and right. And the poor ego is trying to make both of them happy and operates in the reality principle, trying to make both sides happy. So, what according or in the psychodynamic therapy, um, the assumption underneath everything is that these unconscious motivations and drives are what's leading to the psychopathology. And so, if we can take some of this unconscious stuff and make it conscious, make you aware of it as a client, I'm sorry, as a patient, then you would your behavior would become more adaptive. So psychoanalysis is the Freudian therapy that involves making the person more aware of their unconscious thoughts. How is this done? Well, one technique that's used is free association. So the patient is supposed to say anything that comes to mind when the therapist says something. So the therapist says mother and the patient says father. The therapist says dog and the patient says cat. And then maybe the therapist says bike and the patient says danger. And the therapist goes, wow, all right, there's something going on here. There's something about a bike and danger that's not typical, so to speak. There's some unconscious thing going on about bikes and fear. Let's look into that. And they're going to use all different techniques to try to let what is unconscious become conscious, bring it up. Some of what they're going to do is dream interpretation. They're going to discover the symbolic meaning in patients' dreams. So when a person dreams, let's say the patient comes to the therapist and says, the other night I had a dream that my teeth fell out. Well, the teeth falling out is what would be called the manifest content. That's actually what the person dreamt of, the overt storyline. And then the therapist starts to look at, okay, what does this mean? What are the unconscious drives that are underneath all of this? And what is basically the latent content of the dream? So the latent content of teeth falling out might mean that you're afraid you're losing something of value to you, or you're afraid of aging, and your mortality is becoming more, your fear of dying is becoming, you're dealing with that. You're trying to process that. So this is the unconscious drives being made more conscious. Now, psychoanalytical theory, psychoanalysis, psychodynamic therapy takes a very long time. We're talking about 2 or 3 hours each week for years. And so I don't even know of one therapist in Lawton who uses psychoanalysis or the psychodynamic therapy. It just is way too long. Insurance companies are not going to pay for it for this long, for this many sessions. The reason why I'm teaching it to you at all and why it's even in your book is because this is what you see if you look at TV and cartoons and that. Oftentimes, if you're watching a movie or a joke or a comic strip, they'll show a client lying on a couch and the therapist is sitting in a chair taking notes and isn't even looking at the client. Like the client and the therapist are not eye to eye having a conversation. That is Freudian therapy. That is psychoanalysis. That's psychodynamic therapy. So, it's depicted in TV and cartoons a lot. And so I sort of want you to know about it, but know that it's not the predominant therapy that we use now. Okay, another type of talk therapy is play therapy. This is a technique using play that helps the clients resolve difficulties. So this is used a lot with children. I know when my son was going to a therapist for his ADHD when he was like 8 and 9 and 10, they did not sit in a chair and talk to one another. First of all, he's got ADHD. It was hard for him to sit. But then more than that, as a child at that age, he wasn't going to express his emotions verbally as well as he could play them out. So if someone was watching him and his therapist together, it looked like they were playing basketball with this little hoop. It looked sometimes like they were playing with Legos. But while they were playing with Legos and while they were playing basketball hoops, there was lots of talk about different things and lots of, if he hit it really hard, she'd say, wow, you're hitting it really hard today. Are you angry about something? Do you seem to have energy? And so they were able to address topics using fantasy, using stuffed animals, using Legos, using in all different ways, and it is a very effective therapy. Now, I don't want you to think it only is for children, because it's not. This sand tray therapy and sand play can be used very effectively with adults. In fact, well, you guys are students, so you guys get to use the Wellness Center at Cameron. But if you're a member of the community, like maybe you've got a neighbor or a family member who needs therapy and their insurance won't cover it, or they're unemployed right now, and they can go to the Cameron Psychology Clinic. We call it CPC for short. It's right next to the theater. And at the CPC, they get therapy for free from students who are in their last year of their master's work to become licensed professional counselors or licensed marital and family therapists. And they're overseen by people who are licensed as they're doing the therapy. And so it's a great way to give people access to mental health care who don't have it in our community. And it's a great way for our students in their last year of training to get hands-on while supervised. But at the CPC, we have the sand tray therapy, and it is amazing. I was able to watch a video once, and I could never see the client's name or client's face, but the adult was clearly playing with the different things in the sand tray, and she had moved a bunch of the little play people in one area and had herself far separated. And the therapist said, "Oh, is there a reason why you're separated from the other people in your family?" And it brought out a whole bunch of issues that she was having, gave her a way to talk about how she never really felt like she was part of her family. And I just don't want you to get nervous hearing that I was able to see that. I was able to view that when I was chair of the psychology department, and we were showing clips of it. The client had agreed to let us as part of our recruitment effort for getting people to donate money to the CPC, and to recruitment effort to have students go to our master's program to become therapists. So that was the only reason why I had access to that. Otherwise, if you don't work at the CPC as a therapist or as a supervisor, you don't have access to any of that information. Okay, so that is play therapy. Now let's talk about the different behavioral therapies. And behavioral therapies are great. They're built on the basics of learning, and we will get to the learning chapter in the next exam. So this is even going to make more sense after you've had the learning chapter. But in learning, what we think is that there's associations that are created. And so some of psychopathology exists because poor associations were made. We can also create associations that can make behavior more adaptive. So let's say you've got a drinking problem, that you're not comfortable with how much you're drinking alcohol and you want to drink less. Well, one way that we could have you drink less is if we could give you some negative thing, some aversive thing would happen every time right after you drank alcohol. Then you would learn to associate being alcohol with this really awful thing, and alcohol would become less desirable for you. So they've done this. They've come up with a drug that you take. And if you take the drug in the morning, and you take it every morning, then if you drink alcohol anytime during that day, the mixture of the alcohol with that drug will make you violently sick. You'll vomit and vomit for several hours. So the idea is, after you've had several pairings of the alcohol with the vomiting, alcohol with vomiting, alcohol with vomiting, that now the idea of drinking alcohol is no longer attractive to you and you don't want to do it anymore. Of course, the problem here is that what some people will do is they'll stop taking the drug if they know they're going to have a drink that evening. So it's not perfect, but you could see how it's using this behavioral approach. And again, you'll understand this even better after we do the learning chapter, which is in the next set of materials. Exposure therapy and systematic desensitization were shown to you last week in that video that you saw with the woman who had the phobia of birds and feathers. So what you were specifically seeing there was systematic desensitization. Remember how the therapist first had her sit in the room with the feather, and then the feather got closer and closer and closer to her. But remember how self-directed it was. She was the one who would say, "Oh, yes, you can bring it closer to me. Okay, I'm ready for this now." It wasn't like the therapist was putting it right up to her. Ah, no, it wasn't like that at all. So it's very slowly getting the person to become more and more comfortable in with having the feather around, and then eventually the whole bird could be in the room and she'd be okay. Exposure therapy is similar to systematic desensitization. It's just you're going to give them more of it. So maybe you're going to give them the whole bird right at the beginning instead of begin with a feather. Exposure therapy can work great, but it can also make someone more traumatized and they run from the room and they'll never come back to therapy. So you need to sort of know your client and know which one is going to work better. So those are some behavior therapies. This is the example of the spider. Eventually, the spider can crawl on the person's arm after this systematic desensitization. There's also a bunch of cognitive therapies using a cognitive approach. So the cognitive approach basically says that a lot of maladaptive behavior comes from your thoughts. And so changing your thoughts can be helpful. So let's look at cognitive therapy. So let's say let's say my husband leaves me. And so he has an affair and he leaves me. And I'm sitting there going, oh boy, that's awful. We've been together over 30 years. I'm going to have to rebuild my life. Well, that's probably going to be pretty adaptive as I grieve the relationship I was in and try to build a new one, maybe by myself or with someone else. But what if in response to his leaving and having an affair, I decide my thoughts are, I'm unlovable. No one will ever love me again. I'm going to die alone in an alley all by myself, and I won't even be found for weeks and weeks. Well, those irrational thoughts are going to lead me to have a lot of anxiety, a lot of depression, and possibly a lot of maladaptive behaviors. So what we could do is get me to think differently about this situation. And in addition to getting me to think differently about it, let's go back to, let's say I'm having these thoughts. I'm unlovable. No one will ever love me. I'm going to die alone. Well, if I have those thoughts, I'm not going to join like Match.com. I think there's one for people over 50, Prime Lives or something. I'm not going to join that. And so I'm probably going to have it because I think I'm unlovable. And so I'm not going to meet anyone who is going to find me attractive or want to be with me. So I'm getting reinforced over and over. Look, no one wants to be with me. Well, in part because I'm not putting myself in any situations where people could show that they liked me because I think I'm unlikable or unlovable because he left. So it ends up my behaviors that come from those thoughts end up reinforcing the thoughts. So in cognitive therapy, we want to get rid of those thoughts. We want to come up with different thoughts that will be more adaptive. And so some of what can happen is the therapist just says, wait a second, because your husband had an affair and left you doesn't mean you're unlovable. It means right now he doesn't love you anymore. But that doesn't mean that no one is ever going to love you or that you're unlovable or that you're going to die alone. And so the thoughts get really examined. In RET theory or rational emotive behavior therapy, oftentimes these irrational thoughts are really discussed at length. So let's say a person says, or thinks, if I'm lovable, then everyone will love me and everyone will like me. And I just met this person who doesn't like me, so therefore I'm not lovable. Well, in RET therapy, the therapist is going to say, okay, wait a second, you've got an irrational thought. It is irrational to think that if you're lovable, everyone will like or love you. That doesn't exist. There isn't a person alive that everybody loves or everybody likes. So no matter who you are, no matter how lovable you are, there are going to be people who will not love you, who will not even like you. There'll even be people who hate you. And it has nothing to do with you. It has to do with them. It has nothing to do with your value or your lovableness. And so pointing that out to a person, and it's more than just pointing it out, it's helping them to see that belief that if they're lovable, then everyone will like them or everyone will love them is irrational. And so getting them to see that lovable people have people who don't like them, can make them react differently to their environment and make them less depressed, less anxious, things like that. Now, cognitive behavior therapy seems to take the best or all the good stuff out of the behavior therapy that we talked about in the last slide, and the very best out of cognitive therapy, which is in the beginning of this slide. And it creates a whole new therapy. It's a combination of cognitive therapy and behavior therapy. And it is right now one of the most popular therapies out there. Part of the reason why it's popular is it's quick. In 4 months, you can usually meet all the goals that you have, 16 sessions going once a week for 4 months, and you're done. It's successful, so insurance companies love it. We call it CBT for short, cognitive behavior therapy. And what will happen a lot of times if you're seeing a cognitive behavioral therapist is they're going to give you homework. And so let's say there's a behavior that you're doing, I don't know, you canceled with your friends, and you're feeling lonely and a little depressed and you are longing to have social interaction and social connection, but when friends make plans with you, you keep canceling at the last minute. And so what a cognitive behavioral therapist might do is say, okay, I want you to start keeping a log. And every time that you cancel with your friends, I want you to write down everything that you were thinking, feeling, doing before you canceled with your friends. And I want you to write down everything that happened in the hours that followed canceling with your friends. What were you doing? What were you thinking? What were you feeling? And I want you to bring these logs into me and we're going to discuss them. And so you show up to therapy the next time, and you've now got maybe 5 instances that happened in the last week where you canceled out on people. And you guys look for threads, you look for patterns, you look to see what are the antecedents, what are the things that are happening before this behavior, and what are the consequences of the behavior. And what can we do to think differently about the situation that could lead to different behaviors? And one of the reasons why CBT therapy is so popular is because it's one of the theories that is called evidence-based theory. In other words, when we do research, it's easy to show that CBT therapy works. Now, how do we do evidence-based therapies? How do we know? How do we do studies to know what's an evidence-based therapy? Well, here's an example. We might take 100 people who have been diagnosed with bipolar disorder. And we're going to randomly assign these 100 people into 2 groups. So one group, we're going to give them different therapists who are all going to use cognitive behavioral therapy on. And they're going to see them 1 time a week for 16 weeks. The other people are going to be randomly assigned to a control group. And in this control group, they're going to be told that they're on a wait list, and that as soon as an opening comes available, they'll be called and they'll be told that they're going to get therapy soon. So some get cognitive behavior therapy, some are told you're going to get cognitive behavior therapy soon. And what they find, then they look at the symptomology before they start the therapy, during the therapy, and then even 6 months after. So they might check in with them every other week for 6 months after the therapy ends, maybe even a year or 2 years later. And what's found over and over again is that those that are in the treatment group that get the cognitive behavioral therapy, their symptoms are reduced in severity and stay reduced even after the therapy is over, much more so than those in the control group. Now, cognitive behavioral therapy is not the only therapy that's evidence-based. There's lots of these therapies will work. I mean, we have evidence that they work, but this is how we show that a therapy works. As a side note, sometimes there's a third control group where they're just told nothing. So you have bipolar, you're in a depressive episode, you're in a control group, nothing's going to happen. And what they find is that oftentimes people in a true control group where nothing happens to them at all, they get better with time too sometimes. Now, why would that be? Well, because oftentimes these disorders have a little cyclical feel to them. You get better and worse and better and worse and better and worse. Oftentimes when you're seeking out therapy, you're in one of the worst sections. And if you wait 3 or 4 months, sometimes things get better on their own. Now, what I don't want you to hear by listening to me say that is, well, I should just wait and things will get better. Those that get therapy do that much better than those that are in a true control group. And those that think that they're going to have therapy in the future tend to do better in a control group that are just told you're going to have, like, there's nothing for you right now, nothing's happening. So just even the hope of knowing you're going to have therapy can make people feel a little bit better. But actually having the therapy really works the best. Okay, so that's cognitive behavior therapy. There's also the humanistic approach, and the humanistic approach is really interesting. The humanistic approach comes from the idea that you know you better than anyone else knows you. And you know, somewhere in you, you know what you need to become less anxious. And inside you, somewhere, you know what you need to become less depressed. And so the best person to treat you is you. But you've had people around you, maybe friends, family members, who haven't really allowed you to really explore you. Maybe there isn't a safe environment where you can sort of take this map out of who it is that you're to be, or what would be a way for you to be optimal. When you take it out and you start talking about, maybe I'll do this, you get feedback like, oh, that's stupid, or you're not thinking about it right. And you quickly fold that back up and hide it way back down in yourself and don't share it with anyone again. So in therapists who take the humanistic approach, they don't even call they call their clients clients. They don't call them patients. Think about Freud, psychodynamic therapy. The therapist knows all and the client knows nothing. The client doesn't even know what their own desires are. It's all unconscious. So the clients are referred to as patients. And you've got this doctor-patient model where the therapist knows more than the patient and is going to let the patient know more. With the humanistic approach, very different. The patients aren't called patients, they're called clients. And the therapist is very much like, you know you better than I know you. And I'm not going to be directive. I'm not going to come in here and say, did you do your homework? So what happens before this? Or we need to start talking about your thoughts, and I'm going to tell you which ones are rational and which ones are not. None of that happens. Instead, it's very much like, what do you want to talk about today? It's very open. You know you better than anyone. I just need to give you a safe environment and a safe way to look at you, and then you'll know the best way to heal. And so there's the therapist practices unconditional positive regard, no judgment at all, accepting the client for who they are. And the idea is that really the therapist faces the client with an attitude of, you are amazing, you are unique, you are here on the planet, and planet Earth will not do as well if you are not all that you can be in here. That Lawton Fort Sill, our community, is not going to be as great without you in it, and especially not as great without you in it working optimally the best that you can be. So what can we do to make you the best that you can be? And only you know what the best you is. And I'm here to just help you talk through and think about and explore things that will make you the best you that you can be. Because we'll all be better off if amazing you exists on this planet and amazing you is here in Lawton. And so you can see what a different approach that is from the psychodynamic approach or the behavioral approach or the cognitive approach or the cognitive behavioral approach. So, okay, now all of these therapies, or most of them, can be done individual, group, or as a family. I say that, but the caveat is psychodynamic or psychoanalysis can only be done as individual therapy. But all of the other therapies can be done individual or group or family. So individual therapy, you are going to meet one-on-one with your therapist, just you and the therapist. Sometimes you'll set goals, you might have homework, and you'll meet either weekly or bi-weekly for a year, sometimes longer, sometimes shorter. In group therapy, you're going to bring together a group of people, maybe 10 or 12, who have the same disorder. Now, one of the advantages of this is you get to share the cost because you're all paying for one therapist, a lot less expensive. Also, it can be wonderful to hear that someone else has an anxiety disorder Group therapy tends to work really well with the personality disorders. So you're talking to someone else who also has histrionic personality disorder. And it's really nice to hear, wow, someone else is going through some of the same things I am. And what are they doing that's helping them? Let me try those. What have they tried that didn't work? Maybe those are areas I don't want to go. I don't want to go down with that. That might not be the best approach for me to take. So you can see how group therapy could work. And then family and couples therapy is very useful. One of one of the master's degrees that we have here, there's a track that gives you all the academic credentials you need to become a licensed marital and family therapist, an LMFT. And what in family or couples therapy, the assumption is that no matter who has the disorder in the family, that disorder affects the entire family. And so let's think for an example about someone who has a substance abuse issue with alcohol, and they drink a lot and they go in these benders where they're not around. So the rest of the family sort of learns to manage okay without that person there. They don't depend on that person to do anything, and everyone just sort of goes around that person, stays out of their way. And this person goes to therapy alone, and maybe they even go away to a residential center for 60 days, and they're no longer drinking and everything's great. And then they come back to this family system. Well, this family system doesn't really know how to incorporate a sober dad. Like, we don't really rely on dad because he's not really around, he's not reliable. Well, it's almost as if the rest of the system, the rest of the family is subtly communicating to dad, go back to drinking, because we know how to function as a family with you drinking. We're going to have to redo this whole thing with sober dad. We don't even know how to really be a family with sober dad. And so you could see how, in addition to getting that person individual therapy to help with their substance abuse issue, or maybe group therapy, or both, having some family therapy could be very helpful. Oftentimes when a kid starts doing something, so maybe there's a therapist in our department, Dr. Joni Saylor, who uses this example a lot. Maybe Billy starts biting kids on the playground. And everyone's like, ooh, Billy, you can't do that. Billy, you're going to timeout for biting someone in the playground. And then Billy does it again. So Billy now has to spend a couple days home. So Billy's parents say, why don't we go into some family therapy? And so they take Billy to the therapist's office. And the therapist talks to Billy a little bit, maybe does some play therapy, but is trying to get a sense of what's going on with Billy. And then the therapist says to mom and dad, anything going on recently in the family? And the mom says, why, yes, my mother died recently. And my mother and I were very close. We spoke on the phone nearly every day. We saw each other a couple of times a week. And I'm really sad. I'm grieving. My mom is dead. And the therapist is like, oh yeah, that would be a natural reaction. And dad, how are you helping mom grieve and your wife grieve? And the husband may say, I'm really not sure what to do. She's sad all the time. It seems like if I say anything, I just make it worse. So I've been working a lot, and I have been trying to provide well for my family. And I'm really not sure what to do. And so the family therapist is sitting there looking at the situation, and can quickly see that Billy is probably very anxious right now. Mom used to sit and play Legos with Billy, but mom's sad all the time now. And sometimes she goes in the room and closes the door and cries alone. And no one's sitting and playing Legos with me because dad keeps leaving the house more than he usually did too. And I feel really alone, and I'm really anxious about it. And I'm angry too. I used to have all this fun time with my mom, and there were times where all three of us were together. But now when mom and dad are together, they seem like anxious around one another, or it just seems like it doesn't flow. It's not easy. And we don't laugh as a family like we used to, and we don't have fun times, and things don't seem spontaneous. There's just like this heaviness in my family. But I'm 5. I can't talk about all this. I may not even be aware of it. All I know is that I'm really anxious and angry and think I don't like it. And so I bite someone on the playground. I'm not sure why that would help, but I'm doing this behavior. So you can see in family therapy, sometimes one person will be what we call the symptom carrier. The problem right now isn't really Billy, even though he's the one who's symptomatic. The mom was still doing what she needed to do, and the dad was being hyper productive. Now he's going to work all the time. So it's not that they're not functioning well, but as a family, things are changing and not for the better. And so with family therapy, the therapist can help the mom grieve and see how normal grieving is and give her strategies for helping her grieve, and help the husband support the wife's grieving, and help the husband to see how important it is to sit on the floor with Billy and play with Billy. And both of them need to help Billy understand what's going on. Now that grandma's gone, mom is sad, and this is normal, and it won't last forever, her being sad. But this is a normal thing that happens when people that we love go away. And so that's family therapy and couples therapy. Okay, so we've talked about these now. All right, now let's talk about the biomedical therapies. So we've got drug therapies that exist. These control psychological disorders through the use of medications. And these are great. There's basically 3 diagnostic categories that work really well with drug therapy: anxiety disorders, mood disorders, and schizophrenia. I think it's a good idea to look at the table at table 16.2 on pages 618 and 619. Has a lot of good information there. But I also want you to know that drug therapy, as good as it is, as great as it is, really, is it almost always works better with psychotherapy. So it's almost always best to do the drug therapy and the psychotherapy. Do them in combination and you'll really get tons of benefits. So there's a group of drugs that we call anti-anxiety drugs, and these are great at lowering our anxiety level, giving us feelings of calmness. It's great for people with anxiety. Another great thing about them is they work really fast, like within a few hours they'll work. The problem with them is they can be addictive. And another problem is because they are they're depressants. If you take them with alcohol or other depressants, you can make yourself so depressed that now you have other issues. So, but these are great. If you have any of those anxiety issues, any of the anxiety disorders, oftentimes they're can be helped by Xanax or Valium or Ativan. All of these work very well. There's some antidepressants that are great at regulating mood. These can be great for depression and for bipolar. Praxil, Prozac, Zoloft, and then there's some old ones, the tricyclics. I always say it wrong. All of these work on serotonin and norepinephrine. They actually look on how the reuptake of these. If you remember from chapter 2, when we had the 2 neurotransmitters, the 2 neurons, and you've got the synapse between them, and how if the electrical current comes through enough, using the all or none principle, that the neuron fires, that then those the neurotransmitters will seep into this synapse, into this space. And some of those neurotransmitters are serotonin and norepinephrine. And then it seeps into the dendrites of the next neuron, and that fits in like a lock and key. So if there are too many locks, so there isn't enough of these things, or too many openings so that you get too much in there, then we can end up having problems with depression. And so these antidepressants work on serotonin and norepinephrine and are wonderful at controlling things. Now, the negative things about this is that it usually takes about 2 weeks before they start to work at all. And that can be very discouraging. So if you are really in a depressive episode and you feel awful, then you finally get enough courage to make a call, and it takes a week or 2 to get an appointment, and then you go to the appointment, and then it takes a week to actually get the drug, and now it's going to take 2 weeks of you taking it every single day consistently before you feel any better at all. You could see how that would be discouraging. But they build up in your system. So it takes a couple of weeks before there's enough in there for you to feel a difference. Another thing that goes on with these is that oftentimes the first one you try might not be the one that's best for you. And so oftentimes it takes several of them to try and different doses to try before you really find what works for you. I know for two of my sisters, they found the one that worked for them. And it was like, we called it the miracle drug. It took a long time to figure it out, but it was great. And that drug worked great for like 2 or 3 or 4 years. But then not so much. And they started by increasing the dosage, but then eventually for two of my sisters, they needed to add another drug in with it. And they started using combinations. And so since my sisters have been suffering with depression, actually, they're not really suffering. They've been managing their depression really well. They have very productive um, lives. One of my sisters has raised 4 kids, and her husband is a full colonel in the military, in the Army. So you know how much wives have to do for that. My other sister has a master's in social work and has a great job at a hospital in Boston, helping the nurses there deal with their trauma. So they've been handling their depression incredibly well. I shouldn't say they've been suffering with it, but they've been on antidepressants and talk therapists for a very long time. And they've had to, we joke to what they take, we call them drug cocktails, because they're a little bit of this and a little bit of that. And a little bit of this and a little bit of that will work for a couple of years, and then it needs to be tweaked again. So that's another situation that exists with the antidepressants. Now, the antipsychotics work really well for schizophrenia. Haldol, Thorzerine, Abilify, all of these are really good at reducing the symptoms. It can reduce delusions, it can reduce hallucinations, make it so it's possible to have a very active, normal, productive life with schizophrenia. Now, if you have depression and you go to a therapist and then you go to a psychiatrist and you are put on an antipsychotic for depression, I don't want you to think, oh my gosh, the therapist thinks I have schizophrenia and they're just not telling me because they put me on an antipsychotic. That is not true. The therapist is not allowed to hide from you any diagnoses that you have. If you ask, what is my diagnosis? The therapist has to tell you and has to tell you the truth. What we find, though, is that all of these drugs work well for the others. So Xanax and these other anti-anxiety drugs sometimes work great for depression. And some of the antidepressants work wonderful for someone with an anxiety disorder. So they're kind of used interchangeably. And I know several people who suffer from depression and anxiety and are on antipsychotics. So that's part of their drug cocktail. So all of these drugs can be used for, we just use the right drug that works for you. But this is what we tend to start with for certain disorders. Another biomedical therapy, the last one I'm going to talk about, is electroconvulsive shock therapy. And the reason why I talk about ECT is because, well, your book does, but also because it gets such a bad rap. I think it came from that movie One Flew Over the Cuckoo's Nest, where Jack Nicholson's character, they give him ECT as a punishment and as a way of the nurse trying to control everyone who's in the psychiatric hospital. But ECT has really been found to work wonderfully with depression that is resistant to drugs and resistant to psychotherapy. And it's very controlled and it works really well. So I've got a very short video. I think it's like 2 minutes. No, I think it's 3 minutes long. So there's a short video that I've put after this as part of the required videos to watch this week that gives you a little bit more information on ECT. As of right now, 2021, I don't know of anyone who in Lawton who does ECT, but there is a place in Wichita Falls, and the therapists in Lawton will know to refer you out to places that have ECT if your depression or your family member's depression is resistant to the drug and the talk therapies. So that is all of oh, I forgot to say this. Does therapy work? Big thing. Yes, it does. For most people, it is very effective. It doesn't work for everyone, but psychotherapy works better than a placebo and better than no treatment. And drugs work really well. The medical drug, the biomedical stuff works really well too. And the combination of the drugs with the psychotherapy is the ultimate. It's the very, very best. So we have now covered all of the information for this chapter and for the material that will be on your second exam. Your exam will be next week. If you have any questions, please email me, maryd@cameron.edu or marydz@cameron.edu. Okay. Thank you.